Hello and welcome to our new topic. This lecture focuses on drugs used to treat psychosis and related disorders. Psychosis represents a fundamental breakdown in the brain's ability to interpret reality, and antipsychotic drugs are among the most powerful agents in clinical pharmacology. Their actions are not limited to symptom suppression. They modify neurotransmitter systems, neuronal circuits, and long-term brain signaling patterns. Understanding antipsychotics therefore requires understanding brain function, neurotransmission, receptor systems, and network-level regulation. So, let's start. The learning objectives are shown. These learning outcomes emphasize conceptual understanding rather than memorization. We will link brain function, neurotransmission, receptor pharmacology, and neuronal circuitry to drug action. The aim is to understand psychosis as a neurobiological disorder and antipsychotics as modulators of dysfunctional brain circuits, not simply as symptom control agents. The term psychosis originates from the Greek words psyche, meaning soul or mind, and osis, meaning disorder. Historically, it was introduced as an alternative to terms like insanity and mania. Clinically, psychosis refers to a group of disorders characterized by a loss of contact with reality, with or without insight. This loss of reality manifests through disturbances in thought, perception, emotion, and behavior. Psychosis is therefore not a single disease but a syndrome reflecting underlying neurobiological dysfunction. Psychosis affects behavior, emotions, and thoughts simultaneously. These domains are deeply interconnected through neuronal circuits linking the cortex, limbic system, and subcortical structures. Antipsychotic drugs must therefore influence multiple systems simultaneously to restore functional balance. Psychosis arises from dysregulation of neurotransmitter systems and neural circuits, particularly involving dopamine pathways, but also serotonin, glutamate, and GABA. Modern understanding views psychosis as a circuit-level disorder rather than a single transmitter disease. Abnormal signaling in corticostriato-thalamocortical loops produces disturbances in perception, cognition, and reality testing. Psychotic disorders include schizophrenia and related primary psychotic illnesses, mood disorders with psychotic features, secondary psychoses due to substances or medical conditions, and transient psychotic states. This classification highlights that psychosis is a syndrome, not a diagnosis. Treatment must therefore be individualized based on etiology, duration, and associated conditions. The historical evolution of antipsychotics reflects increasing understanding of brain pharmacology. Early drugs were discovered empirically, while modern agents are developed based on receptor pharmacology and molecular targeting. This evolution mirrors the development of neuropharmacology as a science. Prescription trends show a gradual shift from typical to atypical antipsychotics, reflecting improved tolerability, reduced extrapyramidal symptoms, and better management of negative symptoms. This shift reflects changes in therapeutic priorities rather than pure efficacy. Management of psychosis involves pharmacological and non-pharmacological approaches. Antipsychotics form the biological foundation of treatment, while psychotherapy addresses cognitive and behavioral adaptation. Modern psychiatry emphasizes integrated treatment rather than drug-only approaches. Typical antipsychotics are older agents primarily acting through dopamine D2 receptor blockade. They are effective for positive symptoms but associated with significant extrapyramidal and autonomic side effects. Their classification reflects chemical structure and receptor selectivity. Atypical antipsychotics are heterogeneous in structure and mechanism but share broader receptor profiles. They combine dopamine antagonism with serotonergic modulation, producing better tolerability and improved efficacy for negative symptoms. Antipsychotic action is complex and multi-receptor mediated. Therapeutic efficacy is primarily linked to dopamine receptor blockade, while adverse effects result from interaction with serotonergic, muscarinic, histaminergic, and adrenergic receptors. Clinical effects reflect receptor distribution, not just receptor affinity. Phenothiazines demonstrate graded dopaminergic selectivity and potency. Piperazine derivatives are highly potent with high risk of extrapyramidal symptoms, while aliphatic and piperidine derivatives produce more autonomic side effects. Structural variation predicts clinical profile. Butyrophenones such as haloperidol are highly potent dopamine antagonists with strong D2 selectivity. They have minimal autonomic effects but produce prominent extrapyramidal symptoms. Their widespread use reflects efficacy and availability rather than tolerability. Extrapyramidal symptoms arise from dopamine blockade in nigrostriatal pathways. Tardive dyskinesia reflects long-term receptor sensitization and may be irreversible. Neuroleptic malignant syndrome represents a life-threatening dysregulation of thermoregulation and muscle tone, reflecting widespread neurotransmitter disruption. Endocrine effects result from dopamine blockade in tuberoinfundibular pathways, causing hyperprolactinemia. Autonomic effects result from muscarinic and adrenergic blockade. Cardiotoxicity and retinal deposits reflect drug-specific tissue accumulation and ion channel effects. Atypical agents represent a pharmacological shift from pure dopamine blockade to receptor balance. Their reduced risk of extrapyramidal symptoms and improved negative symptom control reflect broader receptor modulation. The color coding depicts grouping. These drugs block multiple receptor systems simultaneously, producing network-level stabilization rather than single pathway suppression. This explains improved tolerability and broader clinical efficacy. Receptor selectivity determines clinical profile. D2 selectivity predicts extrapyramidal symptoms risk. Serotonergic selectivity influences mood and cognition, and histaminergic, muscarinic activity predicts sedation and autonomic effects. Partial agonism introduces stabilizing rather than blocking effects. Although safer, atypicals still produce metabolic, cardiovascular, and hematological toxicities. Clozapine's agranulocytosis reflects immune modulation. T prolongation reflects cardiac ion channel effects. These toxicities demand monitoring, not complacency. Antipsychotics are used across a spectrum of psychiatric disorders beyond schizophrenia, reflecting shared circuit dysfunction across psychotic and mood disorders. Combination therapy reflects biological complexity. Non-psychiatric uses demonstrate that dopamine and other neurotransmitters regulate nausea, vestibular function, sedation, and anesthesia. This highlights the systemic nature of neurotransmitter systems. These references represent the core authoritative texts for CNS pharmacology. Students are encouraged to use them not for memorization, but for understanding principles. This lecture serves as a conceptual framework upon which all future CNS pharmacology topics will build. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!